All right, it is 2:40. Welcome back from the break. Um, we're excited to have so many participants sticking with us through the afternoon. I'm Roz King. I'm Chief for Scientific Development and Coordination within the NIH Office of Behavioral and Social Sciences Research. The title of our third panel session is Addressing Educational Quality to Advance Health Across the Lifespan. So for the first portion of the session, we'll return to the format of hearing from each presenter for 20 minutes. We'll then follow that by a discussant and then the Q&A session. Please remember to submit your questions using the Slido as we go along, and we do look forward to getting to them in the Q&A. Our three presenters are Dr. Sarah Johnson, Professor and Director at the Rails Center for the Integration of Health and Education and Department of Pediatrics at the Johns Hopkins School of Medicine. Our second presenter is Evelyn Nelson, Professor of Pediatrics at the University of Kansas Medical Center. Our third formal presentation will be from Dr. Reshma Shah, Associate Professor of Pediatrics and Head of Developmental and Behavioral Pediatrics at the University of Illinois, Chicago. So Dr. Johnson, please take it away.
Thank you so much for inviting me to join this discussion. There we go. I'm going to start us off in this session by talking about the links between health and education and how we can advance partnered approaches to promoting life course health and well-being in school settings. Next slide, please. I don't have any conflicts to disclose. Next slide. So today I'm going to touch on three things. First, I'll start by talking about how health and education are working interactively to drive health and health-related behaviors across the life course. Then I'll briefly share about a program we're operating in Baltimore, anchored in school nursing, that's designed to promote health and educational equity or outcomes in a coordinated way. And then finally, I'll touch on how we can advance the science of nursing to accelerate research at the intersection of health and education. Next slide, please. So health and education are, of course, sort of two sides of the same coin. And this foundational idea that we've heard a lot about today is really helpful in explaining why high quality school health can pay dividends across the life course and even across generations. Next slide, please. So first, having more education can create opportunities for better health and for better quality of life. Having more education can provide us with higher incomes, with more material resources, with more opportunities for healthy behavior, with more support, more control over our work and potentially our schedules, and greater access to healthier neighborhoods, including places to be physically active and access to healthier food. So in many ways, education really allows people to make choices that are most consistent with their personal values and preferences. Next slide, please. We can begin to see this relationship while students are still in school. So students who are more academically successful and engaged have lower rates of behaviors that are linked to chronic disease. And that includes better dietary behaviors and physical activity behaviors and lower risk of health-related risk behaviors like substance use. And by the time students become adults, there's a lot of evidence to support the benefits of education for chronic disease and disability prevention. So every year of education is associated with a decrease in poor health, in disability, in chronic illnesses like heart disease or arthritis, and all-cause mortality. Next slide, please. So more educational attainment is also linked to longer life expectancy. And a very nice recent study in Lancet Public Health found that here in the US, each level of educational attainment, so you can see here that's less than high school, some college, and college graduate, was associated with an increasingly longer life. And this analysis also showed that the gap in life expectancy between those with the highest and the lowest levels of education, so in this case, that's less than high school as compared to those with a college degree, is widening. In 2019, people with a college degree lived on average about 10.7 years longer than those with less than high school. So that's up from about 8 years in 2000. Next slide, please. So just to give a bit of context about how this 10.7-year life expectancy gap between US college grads and those who don't complete high school that we saw in this prior study compares to other kinds of behaviors, it's larger than estimates for other established health risk and protective factors that are a major focus of disease prevention and intervention efforts. So just for example, it's bigger than the difference between lifetime smoking versus never smoking. It's bigger than the benefits of adopting a healthy diet in midlife, bigger than the benefit of being physically inactive, or rather the harms of being physically inactive in adulthood, and bigger than the risk of being a regular drinker versus a non-drinker. So by finding ways to support children's educational success and persistence, we may be able to see benefits that are even larger than for many other common foci of our health education messages and campaigns. Next slide, please. Finally, I want to return to this point about education and mortality. And here we have a graph that illustrates the relationship between years of education and all-cause mortality in different age groups in adulthood across the globe. And I want to emphasize two things that stood out to me. First, across the distribution of education, there is benefit to longevity from just one more year of education. And it's critical that we appreciate that every year matters for health. So if we take that to its most basic level, finding ways to get kids to school and to keep them engaged day by day can have such a huge population benefit. And school nurses are really an important and critical part of this. And second, while the protective effects of education matter for everyone, they are most powerful for those in the youngest age group. So that's this group in red here, adults ages 18 to 49. This youngest age group, of course, includes the people who are in the prime of their occupational lives. They are the engines of national economic productivity. They are military service members. They are raising families. So this is a really important takeaway that we are beginning to see the impact of education accelerating over time and impacting younger and younger people disproportionately. Next slide, please. So we've talked about how education can create opportunities for better health, and at the same time, better health supports learning and educational outcomes. So poor health is associated with poor attendance and ability to engage in school, more trouble with concentration and other cognitive challenges, and those, of course, coalesce to undermine educational success and attainment over time. Next slide, please. In the US in 2018, about 30% of school-age children had a chronic condition or a functional limitation. And this is up from 22% in the 1999-2000 school year. Students with chronic conditions can miss school because of illness or because of poor sleep, if they were up all night feeling terrible, because of medical appointments. They may be falling behind, feeling disconnected from peers, from their school health providers who are such a critical source of support, and being disconnected from other trusted adults in the school building. And for those reasons, students with chronic conditions have lower educational performance, are more likely to be held back, are more likely to be chronically absent, and to leave school without graduating and have less educational attainment over their life course. Next slide, please. So given those close, mutually reinforcing links between health and education that we've been talking about a lot today, it makes sense to address the foundations of health and educational success together by building partnerships between sectors. And I think we heard a lot about that in the flash talks a few minutes ago. Next slide, please. And while deepening those partnerships between healthcare providers and educators has been long recognized as a priority, as evidenced by this paper from 2011 by Charles Bosch. That's 14 years ago, in which he talked about the importance of healthier students or better learners. It's been really hard to accomplish this kind of integration for a variety of reasons, including different funding streams and different incentives for health and educational sectors. So lots of these complications that we've talked about today. In a program in Baltimore, we've developed a partnered approach to integrating health and education that's showing significant promise, and I'll talk briefly about that. Next slide, please. So health and education are historically very siloed, sometimes even within school buildings. And sometimes health resources can feel co-located rather than integrated into the school. And often on the health side, the person who most spans this gap is the school nurse. And that's why school nursing is at the center of the model that I'm going to talk about. Given the importance of school-based healthcare providers, I want to provide a very quick refresher of the structure of healthcare in school buildings. And since some of our prior presenters have covered this, I will do it very quickly. Next slide, please. So school health services or school nursing is, of course, the umbrella term for the services that schools are legally required to provide to students to ensure that kids with health issues are able to fully participate in their educational experience. And optimally, this includes direct health services ranging from skilled nursing like trach or G-tube care to medication administration, management of acute illnesses and injuries, or support for students who have special needs. Ideally, it often includes school-wide and population health promotion and disease prevention activities. Often this population health approach is challenging, though, given the level of staffing available and the number of hats that our school nurses are being asked to wear. Next slide, please. School-based health centers, in contrast, are considered enhancement of school health services, so they're not in every school, and they tend to be located in communities experiencing poverty and rural areas. They are essentially pediatric clinics inside of schools, and they can provide acute and preventive care, and many of them provide mental health, behavioral health, vision, and dental services. And unlike school health services and school nursing, participation in school-based health centers requires parental consent. Next slide, please. So in some of the prior presentations, you've heard about the CDC's whole school, whole community, whole child model, known as the WISC model. And it integrates this school-based healthcare with a variety of other components of effective health promotion, like the physical environment, family engagement, and health education. And while this comprehensive and multi-level approach is often advocated for schools, it's rarely implemented, and largely because it takes a lot of coordination among all of the moving pieces that we've talked a lot about today. Next slide, please. So a decade ago in Baltimore, we set out to reimagine and fundamentally transform school health by developing coordinated approaches to improving school health and learning together, guided by the WISC model. Next slide. We're implementing this model at KIPP Baltimore, which are two co-located public charter schools here in Baltimore, and students are enrolled from around the city by lottery. Together, the elementary and middle school students serve more than 1,400 students in grades pre-K through 8 in one building. And they have served as many as 1,620 students. This is the largest elementary middle school in the city. Next slide, please. So the Rails Health Center model is built on a foundation of expanded school health services that are provided by two amazing full-time school nurses. We also provide a full-service school-based health center, which offers acute and preventive care. And our school-based health center is staffed by our equally fabulous pediatric nurse practitioner and a part-time pediatrician. And our school and community partners offer things like vision, dental, and behavioral health services under the umbrella of the Rails Health Center. We have a case manager who helps to connect students and their families with health resources inside and outside of school. And really the hallmark of this program is close integration with the school community. And so that means that teachers and healthcare professionals collaborate to identify students in need of support and wrap around to help them get the care they need. I think a good example of this is that our model directly observed asthma therapy program means that students who have poorly controlled asthma can have their prescriptions delivered directly to school, and they can take their controller medications at school each day with the support of our staff, which has vastly reduced asthma-related exacerbations and absences and ED transports. So next slide, please. We've heard about how health is so much more than health care, and our model includes a whole school wellness program that's designed and implemented in full partnership with our educator partners. So to help prioritize specific wellness and health education programs, we use the CDC's School Health Index, which is an evidence-based assessment and planning tool that many of you may be familiar with. The School Health Index assesses the current state of programs in each of the WISC model categories and domains, and then helps you to prioritize key areas to improve health and wellness throughout the school. So many years ago, after completing the School Health Index and then updating it over the years, we identified 3 key areas of focus: social, emotional environment, physical activity, and health education. We're lucky to have a full-time wellness director who is jointly supported by the school and by their health system. And they coach and partner with school staff to implement programs like redesigning recess and training recess monitors to increase physical activity outside and on playgrounds, and to reduce conflict, to provide healthy eating and cooking demonstrations for families, and coaching teachers to support positive behavioral supports. So they do a lot of work at the intersection of health and education and are jointly supported. Next slide, please. So informed by this WISC model, we built programs out and services for things like staff wellness and health education and physical activity. And we really focused on making sure that these components were integrated. It was critical to us to ensure that the programs complemented and supported each other, and that health services were part of a whole continuum of supports and part of the school conversation and the school day, rather than an add-on or co-located at the school. And this figure provides a single example of each domain of the WISC model. It gives you a sense of what we did, but we won't go through it in detail. But we spent a lot of time trying to make sure that we had captured all of the various ways that we could support kids' health. Next slide, please. So investigating the benefits of school health for educational outcomes is complicated for a variety of logistical and methodological reasons. And for this project, it involved building a whole data collection infrastructure that allowed us to integrate health and educational data over time. But that's been really helpful because it's helped us to demonstrate the impact of the program. So to date, we've demonstrated significant positive impact of this program, not just on student health, but on their educational outcomes. We've shown that there were 2,600 fewer absences per year related to the health center, and about half as much absenteeism among those with asthma and ADHD. We also showed that students who are enrolled in the school-based health center had more growth in reading and in math than non-enrollees over time, even though they had poor academic performance and attendance at baseline. And finally, we showed that every dollar invested in the health center generates $4.20 of net social benefit, largely related to the benefits of our comprehensive asthma programs, which has been, I think, a really gratifying part of this. So next slide, please. So given the important links between health and education and the potential benefits of integrating this kind of coordinated, integrated school health program in order to drive both health and educational outcomes, it's really important that we build capacity for rigorous research to capture these impacts. And we need to build infrastructure to do that in a reliable, rigorous, and partnered way that places minimal burden on our partners who are already stretched really way too thin, and that recognizes their deep expertise in this field. So there are a couple of important things that we can do, I think, to help us generate better, more actionable evidence and to build these sustainable partnerships in which evaluation data that we generate for research is potentially also valuable and useful to our partners. First, we can leverage the expertise of school nurses, and we've heard about this all day. Any research and evaluation efforts need to take into account the expertise of school nurses, who often have the most experience at this intersection and whose buy-in and their full partnership needs to be recognized from the beginning. Second, we really need unified systems for health and educational integration. And sharing and visualizing data is important because it allows us to examine health and educational data together. Ideally, we can leverage these same systems for real-time assessment of student health needs, the impact of our programs, and quality improvement. And I think this in turn really deepens partnerships because there's a really strong opportunity for everyone to see progress together and to become motivated to work together. This is complicated by a variety of data privacy issues, including HIPAA and FERPA integration that we've heard a little bit about today and need lots more work in order to sort of smooth the path. Third, we need to decide on standard definitions of measures and key educational indicators against which we're going to evaluate the progress of our programs. So, for example, are we talking about trying to reduce chronic absence, health-related absences, academic performance, academic growth over time? This kind of clarity is going to allow us to compare and pool data across sites. So work on indicators is really important. And finally, we know that there are a lot of common methodological challenges that make this work more complicated. And it would be really helpful to have best practice accepted guidance for recognizing and addressing those challenges. So those are, for example, selection among people who choose to use either the health suite or a school-based health center where it exists, or ascertainment bias, our ability to know much more about people who use our school-based resources than those who don't. There are also real challenges in lack of appropriate comparison groups. So these are things that the field can do together, that we can advocate for better resources to drive our science forward, with school nurses sort of at the center of this. So for me, there's real opportunity to advance child health and the science of school health together. And I'm really looking forward to hearing about how our shared work together can improve health and educational achievement for our kids. Thanks so much.
Excuse me. Thank you so much, Dr. Johnson. And we've got a few questions, so keep them coming, folks. Dr. Nelson, are you ready?
Thank you for that wonderful presentation, Dr. Johnson. I appreciate the chance to participate on the panel this afternoon. Next slide, please. I just want to start off with a quick thank you with admiration and appreciation to the families participating in our work, our community partners, our academic collaborators, and our funders. I'm especially grateful to the INR for support about the HERE study that you'll hear some about today. Next slide. So I hope to cover today, first, to provide the rationale for school-based community health workers within rural communities in order to advance health and academic outcomes. Second, to describe our Telehealth Rocks program and the Rural Health Network and how it's prioritized an intervention for chronic poor attendance. And then finally, to share just a little bit of information around our HERE study to date and implications for the future. Next slide, please. So I want to start and end my presentation today talking about one of our community partners in Eldon, Missouri. I wish they were here really to share their passion for helping students and families every day. They are a partner with Telehealth Rocks that has really informed the HERE attendance approach. They were among the first school districts in the country to implement school-based community health workers in 2016 and have really been pioneers in this approach. Just to give you a snapshot, Eldon is a small rural district of about 2,000 students. They have 4 schools plus a career center. They have approximately 50% free and reduced lunch. The city itself is about a 5,000 strong population with 2 factories. They're about 15 minutes from Lake of the Ozarks, about 30 minutes from our capital, Jeff City, and about 2 hours from my hometown. So in 2008, they were having really some tough times. They were 450th out of 550 districts in Missouri. 2 of their factories and a large dealership had left the community. They had a lot of teacher turnover and little support in the community. So we'll talk today about one approach that's been important, and we'll see at the end some of the really strong community impact that it's had over time. Next slide, please. So I'm kind of going from the community more to the big picture. When we look at some of the rural and urban gaps, we see some really concerning gaps. A community such as Eldon has about a 2.4-year gap in life expectancy, and that gap between urban and rural areas is widening. We see that this represents a dramatic shift from 25 years ago when urban and rural mortality rates were similar. Next slide, please. We just heard from Dr. Johnson really the powerful impact that the education gradient has, with really significant impacts on life expectancy, as well as outcomes across almost every chronic illness and health outcome that you can think of. We see real gaps in our rural communities with this education gradient. This is largely driven by higher poverty rates in our rural areas. We see on the graph on the right, higher poverty rates across almost every age group within rural communities. So with that higher poverty rate in rural areas, we see lower average educational attainment, fewer resources to support educational attainment, and limited economic returns to education in the local job markets. And with that, again, we really see that education gradient be concerning about the impacts of health with our students, families, and communities. Next slide, please. And how that boils down with the students that we work with, looking more at child health in our rural U.S. communities, we see that rurality is associated with increased risk for overall morbidity and mortality across the child age range. We see higher frequency of ACEs and more exposure to parental death, family economic hardship, violence in the household, risk around incarceration of household members, as well as increased risk around mental health and substance use in household members. Rural youth have increased rates of disability, obesity, poor or oral health, and risk for alcohol and substance use. Rural children have a slightly higher incidence of mental, behavioral, and developmental disabilities, but the real challenge with that is the incidence is similar, but there's a lot more difficulties to access to care, resulting in increased risks of disability. And then finally, while rural students face unique attendance barriers, which we'll talk some more about in just a minute, including transportation barriers. Next slide, please. Our particular work is especially focused in on some of the risks with attendance. So we really see a negative spiral where risk of poor health and access gaps lead to increased absences, which then lead to academic struggles, which increases stress and anxiety, and then just circles back and leads to worse health outcomes. We see that chronic absenteeism predicts lower graduation rates and increased risky behaviors. And especially in rural areas, we do see those increased barriers to attendance around transportation, weather, economic pressures, and other access challenges. We see on the right that this is more attendance across all US K-12. We see that while the chronic absenteeism rates, they are headed in the right direction from 2022 to present, but they're still at increased rates before the 2021 2020 lowest rates. So especially rural areas are at increased risk for the negative impacts of chronic absenteeism. Next slide, please. So our approach, Telehealth Rocks, is a family school community partnership that is aimed to advance a holistic health focus. It aims to meet student and whole family health and behavioral health needs and increase access for families across foundational, prevention, and clinical health needs. So I started in school health in 1999, and I really started at the top of the pyramid there with tier 3, with providing clinical telehealth services. I was fortunate in 2016 to partner with More Public Health and really expand that school health focus, align with the WIS model, and look at clinical early intervention and prevention services, and really have a greater impact with our rural schools with that approach. In 2021, we started and added more that foundational level, that green level at the bottom, where we're also really focused in on addressing whole family needs and prioritizing the needs that families are bringing to the school setting. Next slide, please. We've developed a rural health network, which is, by HRSA's more formal definition, a broad array of organizations from traditional and non-traditional healthcare entities that come together to help address healthcare gaps. Each member in our rural network has one vote in setting the priorities and strategies to address the student health needs. We've used this systems approach really to address some of the highest needs that we're seeing in our rural communities. I think this slide is also helpful. It shows you some of the window picks and transportation challenges that some of our communities face, and barriers both to access and to attendance. Next slide, please. So with the Rural Health Network, your vision and mission is very important to bring a whole set of community organizations together and really to come together around a big mission and an ambitious goal. So our mission and vision is for schools and communities where every child and family has the resources and skills they need to have the exact same opportunity for success in school and in life. And that vision really drives everything that we do together. Next slide, please. So we have a big table. The Telehealth Rocks Family Community School Partnership and Network is a group of over 80 organizations that have come together around our rural health needs for families and students. It includes education, so we include 13 different districts now. It includes advocacy with a range of community social services organizations that focus on the needs of children and families. It includes healthcare. So we're really fortunate to partner with Community Health Center of Southeast Kansas. Dr. Tennyson talked about school-based health centers, and they are real leaders in that area in our state. We also partner with our mental health center, with our specialty mental health through Kansas Medical Center and other programs. We partner with a number of local entities, as well as with our state government and agencies that focus on child health. Next slide, please. We're a growing program where we started in Southeast Kansas, but now we span into Missouri as well. My office literally sits on State Line Avenue, so right between the two states. I think this slide is a good reminder for me that we're growing by state and region, but it's a reminder that you've seen one community, one rural community, you've seen one rural community. We see a lot of variability. While we all have the same vision and working for the success of students, that looks very different in our Southeast Kansas versus in our Kennett and the Delta area, where there's just variability in some of the rural needs and resources. Next slide, please. So one of the innovations, and again, really drawing from some of the pioneering work in the Eldon community, has been the introduction of the school-based community health worker. And the school-based community health worker advances services by supporting the whole family in collaboration with the broader school health team, including school nurses, behavioral health personnel, school educators, administrators, really that whole set of folks supporting the student and the family. With this model, you'll see the student and the family are at the heart. We do focus on engagement and family support, student prevention services, clinical services, and training. And the community health worker is really the connective personnel that help across those areas. There are frontline public health workers and service extenders to meet family prioritized needs. This may include income, employment, housing, food, childcare needs, adult and child education needs, healthcare needs and insurance, safety, and other needs. Next slide, please. The CHW have been called the Swiss Army knife of school staff, because they're really there to meet the range of needs that students and families are presenting at the school. I'm going to read just a little bit of the quote. A CHW in our school frees up the administration, counselor, teacher, and school nurse to help all kids focus on the work in front of them and not the roadblocks that are getting in the way. So again, really talking about how each school tailors some of how the school-based CHW, how their work looks based on what needs they're seeing with the family. Next slide, please. So our Telehealth Rocks school-based community health worker program in 2024, we were in 8 schools in Kansas, 5 schools in 5 school districts in Missouri. We worked with 347 families across over 1,000 community health worker interactions. The highest needs that CHW were helping with were around medical and insurance, around housing, around food, and around some of the broader behavioral health and connection with services. Next slide, please. Hand in hand with the work in meeting socially determinants needs has been training. So we also advance a lot of multidisciplinary training where health professionals train together. Our Telehealth Rocks Echo series addresses a range of different topics that our partners have prioritized. It's really an exciting all teach, all learn approach. And the telementoring series are based on cases and case-based learning that come from the sites themselves. Next slide, please. Our network itself is who prioritized attendance as a priority. And that has led to our HERE research. Next slide. So the HERE research is looking at what happens when you have a school-based community health worker focus on attendance and addressing those family and student barriers to attendance. So with that, we've completed the first qualitative interviews to inform the intervention development. And we're in the second phase of the non-randomized feasibility trial, looking at really what's the acceptance of the school-based CHW intervention and what are some of the impacts around school attendance and some other health metrics. Next slide, please. So our next steps with this school-based CHW research and practice, one is to continue to follow the priorities that our network brings to us, and to have their help in interpreting findings and informing our next steps. We have a lot of focus on relational health right now and positive psychology type topics, and as well as a focus on prevention of chronic disease and developing healthy environments together. We're looking a lot at implementation strategies around integrating school-based CHW into varied school settings and role networks. We're working on role definition and collaboration among school professionals, including training and ongoing support. We're looking at integration of the school-based CHW approach and broader state and regional initiatives that are aligned with the WIS model. We're evaluating the impact of the CHW across academic, health, school, and community outcomes, as well as looking at social return on investment, especially with some emerging CHW reimbursement models. Next slide, please. We're really leaning into there's challenges rule, but also many strengths. And working with the communities, we see there's really a value around trust and valuing community, values around resilience and relationship that really have maximized the success of the school-based CHW approach. Next slide, please. And then finally, I just wanted to end with a success story with our Eldon colleagues, the Mustangs. In 2024, they've risen to really the top in the state, 24th in the state on their academics. Industry is back in town because their schools is going well, and they're having success with teachers and students. They're also been very attractive to recruit more industry to their community. I'll just leave you with talking about what the Eldon leaders call rocking chair days. There's a real focus on, we may not see the seeds that we planted immediately, but there's a real belief with Eldon and our whole network that we're going to see those flowers bloom over time with improved student health. Thank you so much. I appreciate the chance to talk together.
Thank you so much. So much in that presentation. Dr. Shaw.
Thank you so much. That was so wonderful. Thank you, Dr. Nelson. Thank you, everyone, for this opportunity. And I recognize I'm the last speaker today, so in additional note of thanks for sticking around. Next slide, please. I have no financial disclosures or conflicts of interest, and a big acknowledgement of gratitude to the NINR, who's supported some of the work that I'll be discussing today, and doesn't necessarily represent their views. Next slide, please. So I'd like to begin by introducing you to Jordan, a 3-year-old who is incredibly bright and curious and loves all things Paw Patrol, but his communication skills aren't quite where they should be. And his parents first became concerned about his speech and language development around age 2. And at that time, they hoped he was just a late talker and that his language would come with time. But now, a year later, he's gained only a handful of words. Their pediatrician recommended speech therapy, but they've been unable to access the services he needs, and they're worried. Next slide, please. And Jordan's story is a familiar one. Many of us know a family like his, whether it's a friend, a relative, a colleague, or even our own, because developmental delays and disabilities are incredibly common. And just really briefly, a developmental delay refers to when a child's not reaching milestones like walking or talking at the expected age, while a developmental disability is generally a longer-term condition and includes diagnoses such as autism and learning disabilities. And nearly 1 in 6 children in the United States under the age of 17 has been diagnosed with a developmental delay or disability. And as you can see on this slide, that's a prevalence exceeding many of the common conditions that we see in pediatric healthcare. And I share this story not because it's common, but because it reflects a broader reality. Families are engaged, they're concerned, and they're doing everything they can to get help for their child. But what I see time and time again as a developmental and behavioral pediatrician is that families often have to walk away without services that their child needs. Next slide, please. And so today I will talk about the essential role of pediatric therapies and educational opportunities for children with developmental delays and disabilities, the challenges families face in accessing these services, and the role school-based services can play in helping close those gaps, and how we might build better connections between healthcare and education systems to support families like Jordan's more effectively. Next slide, please. So we know that developmental delays and disabilities don't follow a single pattern, right? They vary widely in how they present and how they affect a child's daily life. Some children may need minimal support, others may require more intensive and ongoing supports across settings. And while no single timeline fits every child, research consistently shows that acting early can help lay a stronger foundation for development. And we have decades of evidence showing that early childhood education and recommended therapies such as speech and occupational therapies during key periods of brain development, like the preschool years, can support gains in kindergarten readiness, academic achievement, physical and mental health, employment, and civic participation later in life. And the benefits don't stop with the child. When children with developmental delays and disabilities receive the support they need, families benefit too. Research shows reductions in caregiver stress, fewer disruptions to work and income, and improved mental health and stability at home. Next slide, please. But despite these key points, we're seeing widespread delays in access to pediatric therapies. In the United States, about 1 in 10 preschoolers has a developmental delay or disability. Yet some estimates suggest that nearly 50% of these children are not receiving the therapies that are recommended for them. And while there are more pronounced gaps in access among children in rural areas and families with fewer financial resources, even with families with resources like private insurance, engaged pediatricians, and motivated caregivers, services are often delayed. This is not an isolated issue. It's common, and it affects children and families across many settings. And because we know that early language, motor, and social emotional skills support school readiness and later outcomes, when we delay access to recommended services that support these skills, we're missing critical windows for learning. Next slide, please. So if we know these early services and supports matter, why are so many children still not receiving them? And I'd like to highlight a few of the contributing factors. So first, the systems families must navigate can be complex. So identifying a concern, obtaining an evaluation, and securing therapy requires persistence, time, and a working knowledge of multiple systems. Second, there are workforce shortages. Many communities, especially in rural areas, as Dr. Nelson had mentioned, lack enough speech and language pathologists, occupational therapists, or developmental specialists. And even in urban settings like Chicago, where I practice, the wait time to see a developmental specialist can exceed 18 months. Third, policy and insurance regulations can also further slow access. So some insurance plans won't authorize therapy without a formal diagnosis, but if families are waiting many months for an evaluation, then services again are effectively delayed. And then there are also constraints in pediatric healthcare. Studies show pediatric healthcare providers often face limited visit time, a lack of system level support, and uncertainty about how or where to refer. Next slide, please. And so this is where school-based services can play a really important role, especially when these clinic-based services are delayed and unavailable. Under Part B of the Individuals with Disabilities Education Act, schools are required to provide free and appropriate services such as speech and occupational therapy to eligible children ages 3 through 21. And while school-based services are designed to help children succeed in educational settings, their impact often extends far beyond the classroom. Skills developed through school-based services, such as communication, emotional regulation, and social interaction, can translate to better functioning at home and in the community. And in fact, national data shows that nearly 55% of preschool-age children who receive these services exited into kindergarten with age-appropriate cognitive, behavioral, and social-emotional skills. And so while school-based services are not meant to be a substitute for clinic-based services, they can play a really important role in helping ensure that children receive timely support, and they can be particularly important for children whose families are facing long delays in the healthcare system. Next slide, please. So you might ask, okay, if school-based services are delayed, why aren't families pursuing school-based services then? And I think that is a fair question. But here is the issue. Despite being federally mandated, these services are not reaching many of the children who need them. And part of the reason for this lies in how our systems operate. Healthcare and education often work in parallel, but not in partnership. And the result is a lack of communication and coordination across systems. And to illustrate this point, I just want to briefly discuss a study we did to address some of the pediatric level challenges that I had discussed earlier. We offered targeted education to pediatric healthcare providers on school-based services and streamlined the referral process to reduce administrative burdens. And we saw a significant increase in pediatricians' knowledge about school-based services, and the referrals to school-based services more than doubled. But here's what was so striking. Despite major improvements in clinical practice, nearly 80% of preschool-age children with developmental delays and disabilities were still not receiving school-based services both before and after this intervention. So the referrals were being made, but the services didn't follow. So what was happening? Next slide, please. Well, first, I think it's important to be realistic about the process. School-based services aren't something families can just access overnight. You don't just walk into a school, mention a concern, and then expect therapies to start the next day. There's a structured multi-step process that includes evaluation, eligibility determinations, and service planning. And these steps are important because they ensure that children receive appropriate and individualized support. But for many families, the process can feel overwhelming and confusing, and they have challenges completing that process. And at the same time, schools are doing all of this while also managing significant challenges. Many are working under staffing shortages, rising caseloads, and increasing student needs. And they're doing this critical work often without enough resources. So we're left with a situation where families must navigate disconnected systems, the medical and educational, without centralized support. And the consequences are real. Families end up waiting for care during critical windows of development. Next slide, please. And so one promising solution to address this challenge is the use of community clinical linkages. And these are structured partnerships that intentionally connect community and healthcare systems to improve access to recommended services and then to ultimately improve health outcomes. And they're not just referrals, they're designed connections that close the loop between clinical recommendations and a service that's actually delivered. And community clinical linkages have been widely used in adult care. So, for example, linking patients to grocery store blood pressure screenings or gym fitness programs. And they've demonstrated measurable health improvements, including fewer emergency room visits, better disease control, and greater engagement in care. But despite their effectiveness in the adult healthcare world, the pediatric space hasn't fully embraced their potential, especially for children with developmental concerns. And I think that's a missed opportunity. Next slide, please. Integrating a community clinical linkage model into pediatric developmental care aligns directly with the principles of the patient-centered medical home model, and it provides a structured way to bridge the gap between what's recommended in the clinic and what's available in the community, particularly in schools. And for pediatricians, it means better follow through. For schools, it means earlier communication and shared information that can support timely evaluations and service planning. For families, it means less time chasing down services and being able to spend more time with focused on their child. And for systems, it means using the infrastructure we already have, but just in a more connected and purposeful way. Next slide, please. And so to explore this idea, we developed and piloted a community clinical linkage model called Preschool and Me. It's a collaborative effort designed with input from the school district, from child find and pediatric providers, from therapists and families themselves. And included in the model are two key components: a patient navigator who supports families through the school-based evaluation and eligibility process. They provide reminders, answer questions, and help problem solve when barriers arise. And then a medical education care plan, which is a shared communication tool that maps where the child is in the school eligibility process and keeps both families and pediatric providers informed. And the goal is to prevent referrals from falling into a void and to ensure that children actually receive the services that they need. Next slide, please. And we saw some really encouraging results. Pediatricians reported they appreciated feedback on whether school referrals resulted in services. Families missed fewer evaluations, and most strikingly, and a notable jump from before, nearly 75% of families successfully enrolled in school-based services and overwhelmingly appreciated the support, including families like Jordan's, who said, "Without them, Preschool and Me, I wouldn't have known how to get Jordan involved in school and how to set up the IEP meeting. They've helped me step by step and to finally get him into school. Actually, I'm very grateful because when he sings songs, I cry because I'm like, wow." And we're now conducting a larger trial to better understand what's needed to sustain and scale this approach, and also to generate evidence on its effectiveness that could inform broader application. Next slide, please. And through this work, three themes have really emerged that shape how we think about implementation, each one presenting both a challenge and corresponding insights into what works. So one is that clinician bandwidth is limited. Primary care visits are short and they're fast-paced, so any model must fit naturally into clinical workflows. Simplicity and alignment with routine practice are key to feasibility. Two, family stress is real. Families are often balancing caregiving, work, and other responsibilities. Navigating developmental evaluations, especially for the first time, can feel really overwhelming. And this is exactly why co-designing with families has been so important. Their input leads to solutions that are both relevant and usable. Families bring cultural knowledge, advocacy experience, and an understanding of what works in practice, not just on paper. And then communication gaps persist. I think while healthcare and education systems are really united in their commitment to supporting children, they don't share tools like an electronic medical record. And so this lack of built-in communication infrastructure can create disconnects. But we've also seen that with intentional design and partnership, it's possible to bridge those gaps. Next slide, please. And ultimately, this is really about more than one program. It's about identifying models that can be adapted across systems and communities. And I think this is where NINR is uniquely positioned to lead. We need rigorous studies that evaluate real-world scalable models of linkage, targeted efforts that connect families to the specific services they need in the environments where children live, learn, and receive their care, their homes, their clinics, and schools. And this work is inherently interdisciplinary, with nurses and allied health professionals playing an important role in bridging systems. So for example, school nurses, as has been mentioned, often serve as a trusted point of contact for families, monitoring chronic health needs during the school day and ensuring that clinical care plans are carried out in educational settings. And while our work is focused on children with developmental concerns, the community clinical linkage approach can be applied to a range of pediatric conditions. For example, asthma, epilepsy, diabetes, to ensure that care plans that are developed in clinics are known and actionable in school. Next slide, please. And so in conclusion, I think, when systems fail to connect, families can fall through the cracks, but this isn't inevitable. We can design better systems, ones that link clinical and educational care, ones that ensure children actually receive the services they need during important years of development. Programs like Preschool Me offer one potential solution and highlights the need for broader investment in adaptable, scalable, and sustainable models. NINR's scientific leadership and commitment to real-world solutions can help accelerate this work, amplifying the voices of families and supporting the research needed to close these critical gaps. Because the reality really is this: outside the family home, school is where children spend most of their day. And so if we're serious about improving pediatric outcomes, we need strategies that bring systems together and not just leave them operating in parallel. Next slide. And that's it. Thank you so much. Big thank you to my team and my contact information.
Thank you so much, Dr. Shaw. So many moments in that talk. We're now going to move into our discussion and Q&A portions. So we're going to start with our discussant, Ashley Darcy Mahoney, Professor and Senior Associate Dean for Faculty Affairs at the George Washington School of Nursing.
Great, thank you so much. And Dr. Shaw just teed me right up here for the initial part of this discussion. So thank you for the opportunity to really reflect on these powerful presentations. As a nurse and someone deeply engaged in early childhood systems, I want to speak to how nurses, especially those embedded in early childhood and school settings, contribute to outcomes we all care about: improved health, school success, and long-term economic stability for our kids. Many of the powerful presentations today have rightfully focused on the K-12 space, on the critical role of school nurses and school-based services, and the cross-sector partnerships in supporting that. I want to begin by expanding our lens just a bit, as Dr. Shaw started to, because being healthy and ready to learn doesn't just start the first day of kindergarten. It starts well before children ever step foot in a classroom. From the prenatal period through the first 5 years of life, we are laying the sort of neural, emotional, and developmental foundation for everything that follows. And families, especially those navigating complex systems or facing structural inequities, need support during that time. As mentioned, I'm a neonatal nurse practitioner and developmental outcomes researcher. I've spent a career working at the intersection of early childhood and education. My research and practice have focused on advancing early language development and reducing disparities in developmental outcomes. In particular, equipping the nursing workforce to lead upstream. I've collaborated on national initiatives like Talk With Me Baby and Habla Me Bebe, and have led and co-led research to strengthen home visitation and neonatal care models in diverse communities. And what I've learned time and time again is that if we want to shift lifelong trajectories in health, education, and economic opportunity, we must invest early. And we must ensure that nurses are at the table, from birthing hospitals to early childhood programs and all the way through K-12 schools. If we're truly seeking sustainable returns on investment, then nurses must be recognized and resourced as a core infrastructure. So I'm going to make sort of 3 key points in this discussion period. The first is enabling nurses to drive health and drive learning. So Dr. Johnson reminded us that education is one of the strongest predictors of health across the life course, with more than 10 years of life expectancy gap between those who graduate college and those who don't complete high school. She also showed that health enables education. Children with chronic health conditions like asthma and ADHD are more likely to experience absenteeism and lower achievement. These are opportunity gaps where school health and school nurses can thrive and change courses for children. Nurses working in early childcare centers, in pre-K and in elementary schools are also central to reversing this. They must ensure that these chronic conditions are managed early, that screenings are completed, that medications are administered, and that families are supported so that health issues don't derail academic success. And Head Start programs, especially early Head Start, which serves infants, toddlers, and pregnant women, they embed nurses as integral members of the health services team. They can ensure children and families receive comprehensive support needed to thrive, things like health assessment, health education, care coordination. Nurses in these programs help provide this holistic model, which integrates health, education, nutrition, and family well-being. Dr. Johnson spoke about something similar at the Rail Health Center, where we provide comprehensive nurse-led school health services, resulting in fewer absences and increased math scores, and a better return on investment. This is the type of evidence we need to move systems and to move policies forward. Point number 2, nurses as community and family anchors. In rural district, Dr. Nelson's HERE study showed that the reality that students most need in terms of services are the ones that are often missing in schools, especially those in pre-K and kindergarten. Those can have lasting effects. So what are some of the solutions? Well, she mentioned school-based community health workers working in partnership with school nurses and families. And nurses in these settings are trusted anchors who understand how to meet the needs of both health and social needs, from housing and transportation to mental health and parent education. Nurses, particularly in rural areas, are often a linchpin for collaboration, ensuring that the community health workers are integrated, that families are prioritized, and that attendance improves. Dr. Nelson's work reinforces that when trust and health needs are met, attendance and engagement follow. And point number 3, nurses bridge the medical and educational divide, and we need funding and sustainable funding to do that. Dr. Shah's presentation underscored a critical truth, that children with developmental delays and disabilities are often caught between 2 systems, health and education, with often no clear bridge between them. As she showed, even with clinician education and referral streamlining, 80% of children still failed to receive school-based services. This is where nurses come in. Nurses working in these schools are frontline connectors who monitor development, build trust, initiate referrals, and make sure that care coordination happens. In models like Preschool and Me, nurses work alongside patient navigators to ensure families don't just receive a referral, but get through the door. The school setting touches every part of a student's day and profoundly shapes their health and well-being and long-term opportunities. And yet funding for that particular group of people that help to safeguard that particular part of the student's life, nurses, is often fragmented and sometimes insufficient. We know that Medicaid can and does offer a proven mechanism to support and sustain school nurses. It covers almost 50% of school-age children and is the largest payer for child health in the United States. School nurses are often the only providers that see many students all year, and billing for Medicaid for school services such as screening, chronic disease, and care coordination can not only expand care, but also offers an opportunity to offset the cost of employing nurses, freeing up school and public school health budgets. Currently, 25 states allow Medicaid reimbursement for services outside of an IEP, and this crosses red states and blue states. Georgia's expansion has allowed for claiming school nurses to generate potentially up to $48 million more in school funding. Colorado's school-based behavioral health expansion is projected to add $8 million in annual Medicaid revenue. Chicago public school systems often do this, and the National Association of School Nurses and other advocates continue in this call for really advocating for the expansion of eligible services for kiddos. Nurses can lead here. What we've seen today is the intersection of health and education is where kids can feel supported or disconnected. What we've heard today is that health and education can often fail to connect and lead unmet needs, but nurses can bridge them. We are a scalable workforce with demonstrated return on investment can really help to bridge that opportunity gap and help make kids healthy and ready to learn. All the speakers today pointed to this, the intersection of health, education, and social opportunity. And if we want to meet families where they are, to close these service gaps, improve kindergarten readiness, and improve kids to be healthy and ready for a lifelong life full of health, we need to stop seeing school nurses as a nice to have and fund them as an essential infrastructure through all kinds of mechanisms, many of which have been talked about today, and much of which the research absolutely follows to tell us that that's the way to make our kids healthy and successful. So I'd like to, I think, move to Rosalind to move into the question period.
All right, thank you so much for those words. If all of the panelists would like to turn on their cameras, we have a few questions that we have queued up. The first one is for all of you. You've all described partnerships with schools and districts, and we know that this can be quite challenging, and all the success stories here are great to hear. And we're wondering if you might each share a lesson learned or a best practice for people who want to do this kind of research with respect to the on-the-ground process of engaging with the school or district leadership that you've navigated.
I can go first. I think a really important and valuable lesson that we've learned is, the process, as I kind of mentioned, was that in terms of accessing school-based services, is that it's not a linear process, and it does involve multiple people, and depending on where a child, like if they've been enrolled in school or not enrolled in school, there's different pathways, and I think we were seeing a lot of families struggling understanding that process, and then from the healthcare perspective, as a developmental pediatrician, that was frustrating and stressful. And then from the school end too. And what we learned was working with the Child Find partners within our city was just an amazing opportunity to help families kind of bridge that gap and to understand nuances in the process itself. And I just can't thank them enough in kind of helping us navigate the system. And I think it is really important to be intentional about kind of walking through each of those different phases, like that a family actually goes through, to see where those stop gaps are, where those roadblocks are, develop those important partnerships, and to keep everyone abreast of the end results and the successes, as well as some of the challenges that come along the way.
I would say in our experience that this has been one of the most gratifying parts of the process is these deep partnerships, but longevity and listening are sort of at the center. So we came into this with the expectation that we would be partners more or less in perpetuity, and that required us to have a lot of humility and a lot of conversations about what the priorities were. And then we put the school's needs at the center of what we did. So we didn't come in with a discussion about here's what we need to get done. We thought if we want this to be a long-term, stable, and really mutually beneficial partnership, we need to identify what school leaders and school nurses and others in the school thought were the biggest issues, and we were going to tackle those first. And over time, our agendas have kind of coalesced, but it started from saying, what do you need and how can we help? And that's been great.
I would just echo that. I think that we try to show up, be useful, and then try to work ourselves out of a job by solving a problem. So I think, we're just as Dr. Johnson just said, we're in it for the long haul. We've had more money, we've had less money, but we're here to continue to listen and work together as partners. So I really agree with what was said.
Thanks. I don't know if our discussant wants to chime in with any thoughts on that. Okay.
I think they got that one.
All right. So we have another question. This one is where'd it go? Here we go. For Dr. Johnson, Someone's wondering about how did you collect your data from which databases, and do you have any suggestions? They want to know if you specifically use the CRISP Maryland HIE data, and do you have suggestions for people who live in other states on how they could do comparable research?
Yeah, it's a really good question. So there are programs in Maryland that are using the Health Information Exchange data, in particular to mostly guide clinical care, but we do not have access to it for research. And it was just sort of getting started when we started this program. We built all of these data systems ourselves, and they sort of wrap around the educational data systems and the health data systems. And that is not the most efficient way to do it by any stretch. But I think the real opportunity is, and I'd be happy to talk with anybody who has an interest in trying to do this. I think the real opportunity is to find someone who has a template for it and deploy it in your own setting. Like, don't reinvent the wheel. And so we can now use our templates that are coming out of student information systems and are coming out of our health records in order to identify what are the key elements that we need. And we really spend a lot of time with our school nurses and our nurse practitioner to find out what are the reliable and robust data elements, and our school partners about what data do we trust and think are really helpful and useful indicators. So that really, I think, guided a lot of what's in that health system and that data system. But its integration is a challenge, and I'd be happy to talk with anybody about it, because it's something we need more best practices and infrastructure to do, because I think our best opportunity is have those data systems be available to on-the-ground staff so that they can use them to guide their quality improvement as well. Then they become kind of a self-reinforcing part of that ecosystem, which is incredibly useful and valuable to everybody.
Thank you. We have a question for Dr. Shah about how can child care centers help identify infants and toddlers in need for services earlier? And a related question about, the preschool kids are in so many different settings. Some are in child care centers, but there's family daycare centers, there's home with a nanny, there's home with a parent, with a grandparent. How are there lessons from one setting that can facilitate early identification in another setting, or do we have to start from scratch with a whole new research plan for each?
Thank you so much for that question. And I think early childhood centers are such a critical partner in identifying developmental concerns. Part of early Head Start and Head Start, as Dr. Darcy Mahoney had mentioned, part of their mandates are also kind of have early screening programs in place using developmental screening measures. And I think kind of incorporating some of those developmental screening practices, I think would be just such an amazing thing if early child care centers were able to do that. Obviously, I'm fully aware that they have so many other items and action items, on their list that they also have to do. And I think some of it is also, bringing that awareness out there, that, you know, and destigmatizing that process, and then having some connections, because I think screening is important. It's an important first step, but it's not enough. And I think when we ask, I think we see this in, you know, this is a lesson learned, I guess, for that second part of that question, from the pediatric world. Yes, like you can screen and you can be asked to do these things, but if you don't know what to do with those results, then that can be super stressful for those centers and those providers. And so I think it is, again, like kind of building those relationships, building those partnerships to say, okay, like, you know, if this could be a model, and if you find something, or if you're concerned, here are some places that we can refer you to, so that process is installed. I hope I answered that question.
I'd be happy to jump in here too, if that's all right.
Yeah. Yes,
Great.
please.
Yeah, so I think also ensuring that not only is this just in early childcare, but that parents know the sort of different technology options that exist. So for example, the Know the Signs, Act Early on the CDC website is a really wonderful resource to make sure parents know exactly what they're looking for, especially for first-time parents. They may not know exactly when the developmental milestones should be happening. It's a wonderful resource to use. The app we've built with NIH funding, Habla Mi Bebé, has that in both in English and in Spanish for families. And then I just think about other things that are in different states. So for example, in Florida has early steps as part of their early intervention system and surveillance for kids birth to 36 months that are at increased risk for developmental disabilities or delays, nurse family partnership or other nurse home visiting services that exists for first-time moms 0 to 2 that qualify. Those are systems that are already in place that have some of these developmental early identification screenings and opportunities for families outside of just early childcare centers. So there's a lot of systems in place, and I think making sure we try to hook in families with the ones that they qualify for.
Great. Thank you. And a final question for Dr. Nelson. In rural Maryland, at least, there is somewhat of a trend of when redoing a rural high school, to incorporate a community center. And have you, in your areas, also seen that co-location of services and a trend toward that? And do you think that that facilitates the research that you're doing, or would if it were done?
Yes, I think that's a fantastic idea. I haven't seen it so much co-located as just geographically pretty close in the same block, those sorts of things, but I think it's a fantastic idea. We've had some innovative co-location of a kindergarten in some of the community. So we're kind of seeing some other kind of innovative things. But I love the idea of the community center co-location.
All right, well, we are at the end of our time, and I want to thank you all so much for really the wonderful presentations in this session, and the discussion, and the engagement by people watching who've submitted questions. And I want to hand back over to Dr. Blackman-Demner.
First of all, I just want to extend a huge thank you to everyone. I think there's one more slide. Let's see. Okay, yes, if you have follow-up questions, and then I think the last slide is our thank yous, which I just want to spend a moment on. Yes, I want to just thank everyone for all the speakers, the NINR staff, and the OBSSR staff, and our contractor who made this event possible, for all of you who stayed on till the bitter end. We know it's been a long day. It's been some really, really great discussions. Again, a reminder that this was recorded, and portions of this, as well as a meeting summary, will be available at some point on our website. And for all of our speakers, and discussants, I'm sure will be reaching out to you as we consider what our next steps are, and please feel free to reach out if you have additional thoughts. And again, thank you to everyone, and I hope you have a wonderful evening.